Hi, now we go back to Spain. I'm very happy to present a big friend and fellow master at WEEC Barcelona like me, Dr. Ramon Asensio. Dr. Asensio got his degree from the Universidad Alfonso X El Sabio in Madrid and then finished his master and post-graduation degree in restorative aesthetic dentistry at the Universitat Internacional of Catalunya in Barcelona, Spain. Nowadays, he runs a private practice dedicated to oral rehabilitation and aesthetic dentistry in Madrid, practicing as well in Barcelona and Toledo. He still lectures and is a member of faculty at WEEC in both restorative dentistry and periodontology. From his experience throughout the years, Ramon will lecture today about soft tissue management from provisional to final restoration. How do we do it? I'm really looking forward for his presentation. See you soon.
Hi everyone, I'm Ramon Asensio from Spain, and today I would like to share with you an hour lecture about soft tissue management in the aesthetic zone, especially related in situations where we have to rehabilitate implants. First of all, I would like to thank Dr. Joao Borges and Rui Pereira Acosta for the kind invitation to be part of this select group of clinicians in this International Aesthetic Master. For me, it's an honor to be part of this kind of professionals, and I will try to share with you some tips and tricks about these situations in the clinic. So, let's start with a small video where you can see what we are going to explain next. But let me just tell you that the important concept that I would like to share with you today is not just related to the aesthetics, but to the long-lasting restorations in the healthy environment, which for me it's the main goal in dentistry, and especially in these situations where we have to rehabilitate implants. For instance, the management of these situations and the protocols that we use are not always the same, because for us every patient is different than the other, and as well inside the mouth of our patient the same tooth is going to be treated in different ways, because it's impossible to do the same protocol all the times. For us, it's important to go for an individualized restoration, and in this way we have to adapt our treatment to the situation that we are going to face. Let me just start with this Roman saying that in English it's all the ways leads to Rome, or all the roads leads to Rome. This is very important, and I found it in an editorial of the International Journal of Aesthetic Dentistry, and it's right by Alessandro de Vigus. And I completely agree with him when he says that there is no wrong or right, but definitely a room for discussion in dentistry. That's really important, because maybe I will show you some situations that I perform a treatment but maybe you will face the same situation with another protocol, and that's not wrong, and I'm not right all the time. But definitely in this kind of situation and in dentistry, we have this room for discussion and to find out how to improve our treatment protocols for the final goal in dentistry, which is long-term healthy restorations for our patients. Let me just introduce a little bit myself. I'm a teacher at the university at Barcelona and Madrid, but I feel very proud to be part of the endo and restorative dentistry department at Barcelona, at Universitat Internacional de Catalunya, because there I study my postgraduate program in aesthetic dentistry, and I learned to love dentistry because when I realized that I've been working for a long time without nothing, and Dr. Roach, the head of the department, opened my eyes and started to teach me how to treat the pathologies that we can find in the mouth. So I'm very, very grateful with him and the department, and I always show this slide. This picture was took on the European Academy of Aesthetic Dentistry meeting 2010 in London, where we present a clinical case and we won the second prize, and finally we published an article, and I feel really proud, and I have to pay tribute to my mentors and teachers, and that's why I always show this slide before I start with any lecture. For me it's really important that people that shows me how to treat patients in dentistry. So implants, what about the special concepts or the important concepts in dentistry, in implant dentistry? Well, one of them is the right choice of the implant system. For me, it's important in the aesthetic zone that we have a reliable implant system like bone level, for example, from Straumann. It's a good tool, the bone level system, to achieve aesthetic results in the anterior teeth. And for me, one of the main important factors when choosing an implant system is the connection, because it can affect the soft tissue management and the soft and hard tissue levels around implants. So let's start with a good choice. After this, it's important to talk about soft tissue. For us, it's really important because if we don't have any soft tissue, or if we don't have the correct amount of volume of this soft tissue, we will have problems to have a nice aesthetic result. So that's why for us it's important to maintain all the time the soft tissue, especially because recreate those tissues with a provisional restoration is not an easy thing. So all the time that is possible, please try to keep the volume of soft tissue from the very beginning. How? Well, you can use provisionals, temporary restorations. Which ones? Well, we can use ovate pontic or screw retainer restoration, or for instance as well, removable prosthesis. In this our lecture, I would like to share with you where to modify this provisional restoration to improve the emergence profile, the papilla height, and the volume of the soft tissue. So for that, I'm going to explain you where to add or where to take out a little bit of material. and you will see with different clinical situations how we do it. As well, I would like to share with you how to manage cases where we are going to treat teeth and implants, because it's really important. It's very difficult to get a nice aesthetic and natural result. So for us, it's main importance to give the lab technician the same substrate, the same thickness for the restoration, and you will see how we do it. As well, it's for me important to share with you the ideal design of an implant restoration in terms of biomechanic, biocompatibility, and biomimetic. There are three different zones in an implant restoration. The connection. In that connection, we are going to use a T-base, a titanium base, prefabricated, or we can do it in CAD/CAM, because the biomechanic is going to be the best. In the zone that we have the soft tissue, we are going to use zirconia, because zirconia gives us the possibility to have a very good biocompatibility. And in the white aesthetic zone, we are going to use feldspathic ceramic, because for us, feldspathics, it's the best material to get a nice, natural looking result with an indirect restoration. As well, if we modify the surface of our zirconia abutment, we are going to be able to adhesively cement those restorations, so we can achieve a very good biomimetic approach, and we can achieve a good biomimetic integration of the restoration. As well, we are going to talk about a little bit one abutment, one time concept, or maybe the so-called reconnections in implants restorations, because some authors think that making more than 3 or 4 reconnections, it's going to be very damage for the soft tissue and hard tissue levels around implants. I think so as well, but I think it's not going to happen all the times in any situation. So the important thing is to find out where and when it's going to be damaged for the final result. Because sometimes we are not going to take out the abutment, we are going to place it, torque, and leave it there forever, if it's possible. And other times, if we have to make 2, 3, 4, 5, 6 reconnections, we are going to do it because we think it's going to be better for the final goal of getting a nice looking and long-lasting healthy restoration. But the important thing, as I mentioned before, is to find out when and how. As well, I will share with you how we select the materials, because not always it's the same combination. For instance, if we have a case like the one you are seeing now in your screen, we have to choose a lithium silicate abutment, not a zirconia, because for the lab technician it's going to be easy to match the shade of the adjacent teeth. So all these concepts are really important, but for me the most important is to work as a team. The teamwork in implant dentistry in the aesthetic zone is very important, and all the members of the team are at the same level. None it's better than the other, because we work together for the final result of a natural looking, long lasting and healthy restoration for our patient. So we all push together to get that result, to get to that point. In implant dentistry, osseointegration is now a fact, but nowadays there are something for me much more important, and that is the perio-pros interface. It's really important how we manage that interface for the long term, because if we do it not in a correct way, we are going to end up with problems such mucositis or periimplantitis, and we all know that resolve that problems or those problems, it's going to be very, very hard and not predictable in every particular situation. So it's important to have a natural barrier, a soft tissue barrier between the abutment and the implant surface, and because that barrier will guarantee the long-term stability of our restorations. For instance, it's very important how we manage the transition between temporary and definitive restoration, because sometimes we make mistakes in this prosthetic manipulation or restorative management, and we end up with problems, as I mentioned before. So for me, it's very important to give a good treatment to that interface, the perio-pros interface, because it's going to be key in the long term. So let's start with the clinical situations. For example, this patient. This is a perio patient that came to the practice for a consultant from the he was sent us by the perio to study the possibility to replace that tooth with an implant restoration, because the periodontist says that that tooth won't stay anymore in the mouth because of the loss of insertion, mobility, etc. So first time I faced this case, I thought it was a really difficult case. But you will see that if we make a good treatment plan and we manage all the situations in the correct way, it's not that easy. It's not that difficult, sorry. So first of all, we took the tooth out, placed a GBR to try to maintain the volume. As I told you at the beginning, one of the most important things is to maintain volume. Because if we have volume, we will have a good environment for an aesthetic result. If we don't have volume, it's more difficult to get an aesthetic result. So in this way, it's not just to make a GBR, but prosto management of the volume. So as well as the GBR, we are going to place a provisional restoration. In this particular case, we didn't place the implant immediately, so we have to make another kind of temporary restoration. And for me, in these cases, when we have the own tooth of the patient, that is the best provisional we can achieve, we can give to the patient. So we cut the root, we fill it with the composite, and we give some kind of ovate shape to the root, and we cement it to the adjacent teeth with fiber, glass fiber. So in this particular case, the combination of the surgery, of the perio and the prosto that we made give us this nice emergence profile, and we maintain the volume. We didn't make any connective tissue graft in this particular case. We just took the tooth out, GBR, and await Pontic with the own tooth of the patient. And that's the result. When we place the implant, we have to do it in the correct way. We have to place in the 3D correct position. And again, you can see the implant placement. And again, we make another provisional. And we can go for an immediate load of the implant, or we can still use the same tooth of the patient as an ovate Pontic, avoiding future problems because of the loading. So it gives us the possibility to push the soft tissue during the osseointegration phase, and to push the soft tissue with a little bit of composite increments in the ovate Pontic design, and get to the head of the implant, making the so-called soft tissue remodeling technique and a traumatic second stage surgery. So once we place the impression cupping, we have the 3D registration, the 3D position registration of the connection of the implant, and we can go for the next step. But in this particular moment, we decide to change the ovate Pontic provisional for a fixed screw-retained provisional restoration. How? Well, we have to empty the inside of the natural tooth, just leaving like a veneer, just the facial aspect of the natural tooth, and fix it with resin to the titanium abutment, titanium provisional abutment. And we change the ovate Pontic provisional restoration with the natural tooth to an screw-retained provisional restoration with the same own tooth of the patient. So we are maintaining all the time the volume from the very beginning to these steps of the restoration. So it's really important when we make a fixed screw retainer restoration that we have in mind that there are two different contours. The critical contour, which is related to the cervical margin of the soft tissue, where we would like to have this margin at the end, and the subcritical, which is from this point to the apical aspect of the restoration till the head of the implant. For me, I make pressure, just slight pressure on the critical contour, and the subcritical will be concave. And with this design of the contours, we can get a nice and easy emergence profile with no problems at all. And in this moment, it's possible to make the final restoration. In this particular case, my lab technician, Kini Garcia from Madrid, decides to use a kind of lithium disilicate, silica-based ceramic system from GC. It's called LISI. Why? Because the environment of the restoration, it's really difficult to match with a zirconia abutment. And for him, it was much more easy to get a nice result a nice result with this silica-based ceramic system. So with the LISI, we can get a result like the one I'm showing you now on the screen. It's important to say that in this particular case, this patient was treated in another city, not the same city from the lab technician, so the communication was a little bit difficult. Maybe the color is not 100%, but for us it's really important to have the exactly same microtexture of the surface, because if other things are not 100% okay, if we have the microtexture, the integration is going to be favorable. So remember to work a little bit, or to spend a little bit of time in making that microtexture. So here you can see a resume of the treatment. First, initial situation with the period effect. You can have a clue of the difference in the margins, level of the margins of the central incisors. Second, the GBR. Third, the place of the pontic at the same time that avoid us to maintain the volume of the soft tissues. No connective tissue graft in this case. Then we push with the ovate pontic modified by resin composite till we have the head of the implant, and we are allowing us to make the final registration. We change the ovate pontic provisional restoration for an screw retained provisional restoration using the same tooth of the patient from the very beginning till this phase of the treatment, and then the definitive restoration. And well, this was the end result. Maybe it's not perfect. I'm not here to show you perfect cases. It's real life. Okay, it's important to have a very, very good light transmission, light reflection, and try to copy the shape and the shade of the adjacent teeth. Very, very important. Here you have a before and after. And 4-year follow-up. As I mentioned, maybe it's not the best case, but it gives us some information about how to handle those situations. Especially, I will be very happy if you understand that the tissue preservation is very important, using ovate pontics, for example, and the material selection. It's important not use all the time the same material, but use the right material for each clinical situation, for each replacement of a tooth with an implant. Let's move to the second clinical situation. This is another patient, young patient who had an accident. He was at the disco drinking a bottle of beer, and a guy went and hit the bottle, and he had a trauma on the central incisor. It happened a week ago, so he came to the practice with an abscess, as you can see in the image. And well, in these cases, it's very important to have a good diagnosis. So for instance, we go for a periapical X-ray, and we find out a horizontal fracture. In those particular situations, it's very important to explain to the patient the treatment options, because it's not just one. We have a lot of treatment options, and we have to explain the advantages and disadvantages of each option, and then the patient have to choose. In this particular case, as you can see in the X-ray, there was a lot of loss of insertion, a lot of loss on bone height in the distal aspect of the central incisor. So we know from the very beginning that it will be very difficult to have a good papilla height in this particular zone of the future restoration. But as I mentioned before, we have to explain the treatment options to the patient. I'm very happy when I have the chance to do this kind of treatments, when the patient understands that the conservative treatment is the right solution. Because if we make a combination of perio, endo, and ortho and prosto, we can have a nice result maintaining the own tooth of the patient. But not all the patients goes for an interdisciplinary dentistry solution. And sometimes, especially when you mention the orthodontics, they say, no, I won't have braces, I won't have any bracket in my teeth, so I would like to have the teeth taken out and placed in an implant. And for me, this is a very sad decision from the patient, because it's very difficult to have a nice result and to maintain that result for the long term. But when we have to do it, I will show you how we approach or how we face those situations. As I mentioned, the second option is to take the tooth out, place a GBR, the implant, connective tissue graft, provisional restoration, and the final restoration. In this particular case, patient doesn't want to have ortho treatment in the conservative multidisciplinary dentistry option. So we took the tooth out, we placed a GBR just to preserve the volume. This is an old case. Maybe in today we can face this clinical situation in other ways. Immediate implant with immediate restoration, something like that. But this was almost 5 years ago, and we decided to make a delayed approach. So, as I mentioned, took the tooth out, preservation, and that's 2 weeks follow-up situation. As you can see, there's no we didn't lost a lot of volume. We still have some volume. The distal papilla is not as high as the contralateral, but it's still okay. It's not too bad at all. Well, this is the post-preservation aspect of the clinical situation, and we have to start to plan to place the implant. As I mentioned, the situation is not that bad. We lost some volume, but maybe we can handle that situation at the same time that we are going to place the implant. Just make a connective tissue graft and gain that volume. As you can see, if we see the situation from the vestibular aspect, it's not that bad. But if we have a look from the incisal point of view, we can see that the loss of the volume was really big. So now the scenario changed a little bit, because it's not that easy to gain all the volume that we lost. Maybe it's not going to be enough with the soft tissue graft. Maybe we have to go for another technique. In this particular case, we thought that we can manage with a connective tissue graft, so we place the implant in the right 3D position, and then from there we have the implant already placed. It has to be deep enough to give us the possibility to perform, to manage a good emergence profile. And the periodontist, in this case Jose Nart, Dr. Nart, the head of the department in the perio area at the Universidad Internacional de Catalunya, who placed the implant and the connective tissue graft. The connective tissue graft, it was took from the tuberosity, because the density of the fibers, we can achieve a stability, which is really important in terms of volume. And there we have the situation once everything healed. And as you can see from this point of view, the volume is still okay, maybe not perfect in the distal papilla, but okay. But if we change again the view, you will see that from the incisal, the lack of volume is still evident. So maybe we can think to make another connective tissue graft, but the patient won't have another connective tissue graft. And well, we can say maybe if we go for a provisional restoration, we can give or we can move labially the volume and hit the volume of the other central incisor. But sometimes it's not that easy with a provisional restoration, because we have to reconnect the restoration for instance, more than 10 times. It depends, no? In this particular case, I didn't want to have a provisional restoration because the implant was placed really deep, and I feel like it was really dangerous to start to reconnect the provisional to modify the subcritical contour, because it won't work very well for the soft and hard tissue around the implant. So I decide to modify the subcritical contour and get a nice biomechanic biocompatibility and biomimetic restoration, as I mentioned, with a modification of the subcritical contour. We have to make a convexity to move the soft tissue labially. So here we have the situation. I perform a digital simulation of what we can get. I just copy the natural tooth and I copy paste on the other side, just to show the patient how we will end up, hopefully. And the patient says, okay, I will be happy if we achieve that point. I say, all right, just let's start. So we took the shade, we pick up the shade from the shade color guide, and we place the impression copying. We took the 3D position of the connection of the implant, and we send the model to the lab technician. So in this particular case, it's very important how we are going to manage the gingiva. So in the lab technician is going to work to make the ideal emergence profile. Once he has the modification of the gingival mask, we can copy that on stone and perform the same, not just in the gingival margin, but in the subcritical contour. And once we have the ideal emergence profile in the hard stone, we can use a provisional wax up abutment to wax the shape of the final abutment, and then scan and send it to the lab, send it to the milling center. In this particular case, to Leipzig in Germany, to the Straumann CAD/CAM, to the Straumann milling center over there, and they sent back to us the CAD design. Once we decide that everything is okay, they mail the apartment and send them back to us. At the beginning, we were using zirconia till the connection, but we start to talk with some colleagues that say they were having or experiencing troubles with those full zirconia abutments. That's why we decided to start to use T-base, and Straumann have the Vario base, which is a prefabricated T-base that give us some better biomechanics on the connection, and we start to feel a little bit more comfortable because it's the same material and the biomechanics is going to work in the same way. So once we have the abutment and the provisional restoration, everything ready, we have to copy the abutment because we are going to place the final abutment, torque, and we won't take it out anytime. So we have to have a copy and a customized copying to take the final impression. So once we have everything ready, we are going to place it in the mouth. So as you can see, we are making a lot of pressure in the soft tissue, but it doesn't bore me. I really don't care about the blenching of the soft tissue. I do care about the movement of that soft tissue. So it's very important that you place the abutment, wait, and then if you can see the patient same day, at the end of the day, maybe a day after, just to see if the soft tissue is following the movement that you will love to have to finish with a nice aesthetic result. So this is day 0 with the provisional restoration, and this is 1 week after. Do you think we have, or do you think we improve the soft tissue volume? Well, we took the provisional restoration out, and you can see that maybe we improve a little bit the volume of the soft tissue, which is the objective of this subcritical contour modification. I didn't like at all the shape of the provisional, so I took another impression, and using this concept of the dynamic compression technique, we designed a little bit over contour provisional restoration to move a little bit the soft tissue, and then start to make some slight modifications, take out a little bit of material to allow the soft tissue to move coronally and feel a little bit the interdental space, and have the possibility as well to perform a nice emergence profile. So this is the starting point, and 2 weeks after placing the final abutment with the subcritical contour design modification, and you can see that we get the volume that we lost with the surgery. So 1 abutment 1 time, we placed the abutment and we didn't take it out, and that allows the soft tissue to make a natural stop, a natural barrier, a biological barrier for the bacteria to get deep inside, to get to the surface of the implant and promote a problem on the implant. So this is the situation. Now the patient is ready for the final restoration. We have to go for a final, but the patient decides that he doesn't like anymore the diastema. So we send the patient to the orthodontist, and from the ortho we got this lateral X-ray. Obviously, the patient doesn't want to have ortho to close the diastema for a long time, and this is a long ortho treatment, so he declines to have the ortho. But I get that X-ray, and it's really nice for me to see the design of the implant, the platform switching, the titanium base, the modification of the subcritical contour in the zirconia, and the veneer preparation on the abutment for the final restoration. So for finals, we have to go for a 0.8 thickness of zirconia veneer, and the 0.1, 0.2 thickness of feldespatic veneer with the platinum foil technique. So it's not easy to get with the platinum foil technique. It's not easy to get an integration of those restorations, but after a few tryings we were able to have a nice result for the patient. So this is a trying of the feldespatic non-prep veneer with the platinum foil, and the trying of the zirconium veneer over the implant. This is the polarized, the cross-polarized photography. Obviously, you will see that the color is not exactly the same, but it's enough for the patient. And that's the final X-ray once we cement both restorations. Here you can understand why I didn't like to connect and disconnect a provisional restoration, because the implant was really deep and it will be very, very difficult avoid a problem if we start to reconnect it. Here you can have some publications about how to adhesively cement a zirconia restoration, and the follow-up. Final result: soft tissue is nice in both restoration. Maybe the shape is not exactly the same, but it's okay for the patient. This is the control CBCT, and we end up with this kind of situation. Maybe, as I mentioned, I'm not here to show you perfect cases. This is just daily basis dentistry. Maybe not perfect, but enough for the patient. But it was really, really difficult to get to the point that the restoration integrated. We had the problem with the soft tissue volume, and we resolved that problem with a modification of the soft tissue. How? The soft tissue. How? Of our final abutment. But anyway, anyhow, we end up with a little bit of difference in the volume of in the labial contour of the soft tissues. That's why I don't like to make implant restoration, because it's impossible for me to get a perfect result as a natural tooth. That's why I think maintaining teeth, it's a good idea always, if it's possible, in the long term with a healthy situation. But here you have the follow-up, 4 years, the restoration are working okay, patient is happy, and we are happy as well. It's important for me, or maybe the take-home message will be that using a modification on the subcritical contour can allow us to get a nice result. Take-home message will be that one about one time and avoiding a lot of connections and reconnections of our apartments can help us to have good stability in the soft tissue levels as well as in the hard tissue. And as well, I will be happy if you understand that if we change the subcritical part of our restoration in the abutment, for instance, we can achieve a better soft tissue configuration in terms of volume. We can move or have a displacement in the soft tissue. Obviously, it won't work if we don't have the volume of soft tissue. Here it's important to have the volume, but not in the right. Here it's important to have the volume, but not in the right vertical, making and convexity. We can move the soft tissue labially and gain that volume that we lost with the extraction of the natural tooth. And as well, the combination with the T-base, with a prefabricated or a CAD-CAM T-base, can help to have a good biomechanics on the final restoration. So let's move to the final scenario, the final clinical situation. It's a patient that have central incisor with a crown, which is not, working really well in terms of aesthetic or function as well. It's giving some troubles. It's a very young patient, and it's important to know as well that she has a very high smile line, which is a really difficult scenario to treat a patient with an implant support restoration, because if we are not very good with the treatment, all the mistakes are going to be visible and are going to make an unpleasant restoration. So we have to keep that in mind and move to the complementary exploration through periapical x-rays. And here in the x-ray we can see that the tooth is really damaged. It's been treated a lot, not just endo but restoratively speaking, and maybe trying to maintain that tooth is not going to be possible in the long term. That's why we decide to take the tooth out, not because of the endo prognostic, but from the restorative point of view, the tooth, it won't be really well restored to be in the mouth for a long time. That's why, as mentioned, we took the tooth out and we start with our delayed protocol for implants. First of all, we're going to make the extraction and the preservation, not just in the perio aspect, but from the prosto aspect as well, with an ovate pontic. Why? Because we are going to try to maintain the gingival architecture, and we will start to draw our emergence profile. As I mentioned, all of the cases, the surgical part, it's performed by Dr. José Nart, who is the chairman in the perio department at Universitat Internacional de Catalunya in Barcelona. I used to work with him in his practice, and I really appreciate the work and the lessons that he teach me. In this particular case, Jose took the tooth out, and obviously it's always the same for the instruction. It must be a traumatic, but especially in the static zone, because we don't want to damage the buccal bone, because it's of capital importance for the aesthetic final result of our restoration. Because the cortical was perforated, Jose placed as well as a resorbable membrane. That membrane gives us the possibility to place our GBR, our biomaterial graft, in the right place. And then we can place a collagen spoon over it and our provisional restoration. In this particular case, we are going to use a removable prosthesis, an acrylic removable prosthesis, because the patient doesn't have money to have another kind of provisional restoration. And that provisional removable, we are going to change the profile in the tooth with some composite, just to try to perform a prosthetic seal of the GBR. The combination of the GBR and the ovate pontic is going to maintain the volume, avoiding a very big resorption, because as we saw in the previous clinical scenarios, the volume is very important for the final aesthetic result. So there are not consensus in the literature about the composite in contact with the soft tissue or with the regeneration biomaterial, but I would like to share with you our experience. This is how it looks like after 15 days of the prosthetic seal with the removable prosthesis modified with the resin composite. It's important to say that in those cases where we are going to use a removable prosthesis, the patient has to wear the prosthesis for 24 hours a day. Just remove the prosthesis for cleaning, but if we remove the prosthesis, the pressure is not in the right place, and we can remove the prosthesis, the pressure is absorption of the volume, and that's why it's important to indicate the patient just to maintain the prosthesis for the whole time. How we are going to design the pontic in the prosthesis and the provisional? Well, using the same concept as we use for the provisional restoration over implants. We have to understand that we have two different zones: the critical contour, which is the cervical part, the cervical junction in a natural tooth, and from there to apical, the subcritical. So to start with, it's the same as we use it for a final restoration over implants. I will have to have a little bit of pressure on the critical contour and symmetrical pressure like in the natural reference tooth, and in the subcritical I would like to have a concavity in this case, just to have room to allow the mix of the biomaterial with the clot, and allowing that to change with the healing that volume for soft tissue volume. And if we have soft tissue volume, it's much more easy to get a final nice aesthetic result. Okay, so let's see how it goes. This is 4 months follow-up. As you can see, there's a little bit of contraction, but not too much. And especially in the vertical aspect. Maybe we can have a little bit on the horizontal, but that's not a problem because as I saw you before, I can manage with the abutment modification or even with a abutment modification or even with a as it's really important not to have a resorption in the vertical aspect because it's really difficult to manage. That's the incisal view, and you can see that the zone it's been in direct contact with the composite, resin composite, modification of the pontic, and it looks really nice and clean and healthy. Well, it's important for me to use a very good composite, microhybrid composite, and well polished, well finished and polished composite, because that will lead to a healthy situation like the one I'm showing you now at the picture. Well, we are now able, after healing of the GBR, to place the implant and go for the second step of our delayed implant protocol, which is placing the implant. If it's necessary, a connective tissue graft, it could be performed as well, and then again place the ovate pontic to keep maintaining the soft tissue architecture as in the first step and act as a approach as well, making the so-called soft tissue remodeling technique. We are going to hit the head of the implant without any traumatic surgery, just adding some composite to the ovate pontic. And that ovate pontic as well, in the osseointegration phase to perform a nice emergence profile, will give the lab technician the ideal contour for the final restoration. So we place the implant in the right 3D position, just allowing a little bit more space in the labial aspect, placing the implant deep enough to have the possibility to have some room to work with the subcritical contour, and obviously we would like as well to respect a little bit of space between teeth and implant, because that will allow to the soft tissue to grow and have a nice interdental papilla. This is 1 week follow-up after placing the implant. Again, we have placed the provisional restoration. So you can see the healing from the incisal point of view as well. No connective tissue graft in this case. It was not necessary, or that was our thinking at the moment. And that's the provisional restoration. Removable acrylic prosthesis, because the patient she could not afford any other kind of restoration. And we have modified the subcritical contour just to get the pressure and the critical contour symmetric to the adjacent natural tooth, which is our reference in this kind of situations. This is 2 months after. As you can see, we are starting to pressure the soft tissue with the modifications, with the small, with a little bit of composite over the ovate pontic, just to get to the head of the implant. And we decide to go for a veneer prep on the natural tooth, because the shape was not really nice. So we are going to prepare that tooth for a veneer. When we prepare for veneers, we always use Pascal-Magne concepts. You know, we start with an additive wax-up, just to try to maintain as much natural enamel as possible, because it will be key in the long-term maintenance of the acute adhesion, and it will be very responsible in the success of our treatment with the indirect porcelain veneer, feldspathic veneer. So, as I mentioned, we start with an additional wax up, and from the wax up we can get some silicone keys, and those keys give us the possibility to prepare just where is necessary to have a path of insertion and a very nice thickness. So we confirm that preparation with the silicone keys, and once everything ready, we can take the final impression. And this is what I was trying to share with you, the second stage, atraumatic surgery through the pontic. If we start to add composite in the pontic, we can hit the head of the implant, and just we are or it's possible to see the healing cap or the healing screw or the closing screw of the implant. So the second stage is just take the screwdriver, get in through the soft tissue and take out, and it's ready for the final impression. So we place the coping and we took the impression, both teeth and implants, and we are now going to see how we manage those situations where we have to match restoration over teeth and implants. And this is the third point of our protocol, which is restoration. We are going to use a bio concept where we are going to try to use the best material for biomechanics, best material for biology, and the best material for biomimetics. And as well, if it's necessary to, change a little bit the shape or move a little bit the soft tissue from one side to other side, we can use a subcritical contour modification of our final abutment. And I will show you how we do it. Always we start with a wax up. It's really important to work with a wax up because it gives us the form, the shape, the information about the final restoration, or how we would like to have the final restoration. Then sometimes we can work a little bit more in the emergence profile on the stone model. The lab technician with the silicone key from the wax up could draw the line of the emergence profile from the wax up, and trim a little bit the stone, and it gives us the possibility to have a little bit more integration of our restoration in that point. We scan the model and we send it to the lab to get the final restoration. We will see how it goes, but let's move a little bit forward with the bioconcept restoration. The bioconcept, as I mentioned before, tries to use the best material in each of the three places, the three main regions of an implant restoration. So in the soft tissue management, it's really important to use this kind of mix of materials, In the zone where we have the connection with the implant, we are going to use a T-base because it's the same material and we will have a good biomechanic. In the zone of the soft tissue, we are going to use a very biocompatible material, which is zirconia. And in the white aesthetic zone, we are going to use a feldspathic veneer because it will give us the possibility to have a nice biomimetic results. So this is a concept that we are trying to publish with some colleagues from here in Spain, and but it's nothing new, because few years ago, in 2008, Pascal Magne and Michel Magne with Jovanovic published this article at the GPD, showing us the use of a veneer over a modified abutment with feldspathic porcelain. In this particular case, it was because to overcome the complication of an implant that the screw hole was, the axis of the screw hole was in the vestibular part. We use it in axes that are on the labia as well, on the lingual, on the palatal side, because for us, if we have a problem in the future, we are allowed to unscrew the restoration. So it's kind of modification of this original idea by Michel, Pascal, and Jovanovic. And Dr. Pascal Magne is working on that. There, with the team from USC, for example, with one of my Mexican friends, Ivan Contreras Molina. They have a very nice publication recently in the International Journal of Aesthetic Dentistry, talking about these concepts as well. As I mentioned, it's not my original idea. I just took some ideas from different publications and trying to put it all together, and we just put that name because I thought it was okay for that. So let's see how we built up the restoration. We wax the provisional abutment with the shape we would like to have at the end, and then we scan it and we send the file, the STL file, to the milling center in Leipzig in Germany, Straumann milling center, and they send back to us the abutment, the zirconia abutment, with the modification of a veneer preparation and the titanium interface. In this particular case, as well, we change the subcritical contour, but not like in the previous case in the vestibular, but in the interproximal. As you can see in the screen now, in the interproximal I have two convexities which are going to help to have a nice papilla height. So we are going to try that abutment. In this particular case, you can see that I'm going to make some disconnections. I'm not worried about that because in this particular case, I think the 3D position of the implant is okay. The volume of the soft tissue it's okay, and the healing of the patient as well is okay. So in my thoughts, this may be a case where we can do all the disconnections that we want, not as the previous case where the 3D position was not okay, the soft tissue volume was not okay, and the healing was not okay. On that particular case, I prefer to place the final abutment, torque, and don't touch anymore. But in this particular case, I prefer to, try in the abutment and, make the disconnections as much as we need to get a nice aesthetic result at the end. So here you can see the abutment in place. Does the abutment look like the tooth? No. But we are, doing restorations and we have to think biomimetically. We have to try to mimic each part of the tooth we are trying to replicate. So in this particular case, the zirconia, it's nothing like the dentin on the natural tooth. So we decide to modify a little bit the surface of that zirconia. Here we have the X-ray where we can see if the fitting is okay, and we modify the pattern. How? We take out a little bit of volume and we place, lab technician place a small layer of feldspathic ceramic, which allow us to have a bonding, a chemical bonding of our ceramic feldspathic veneer over the surface of the modified zirconia abutment, and as well give us the same substrate because it gives us the same color that the natural tooth have as well. So here you can see the configuration of the contours. You can see that the critical contour have a stop and the subcritical is concave, allowing room for the soft tissues. In the interproximal, as you can see in this picture now, there is a little bit more convexity to make a little bit of pressure, allowing the soft tissue to grow in height. Now the abutment looks like the dentin, but there is still one remaining thing that we have to improve, which is the fluorescence, because the natural tooth, especially dentin, it's responsible from the fluorescence of the natural tooth. And if we are trying to mimic the natural tooth, we have to try to mimic everything. And fluorescence, it's part of the natural tooth as well. So lab technician place a small layer of a liner which give us the possibility to have fluorescence on that modified abutment, zirconia abutment. So we have the final model, alveolar model, and Fabian Soto, in this case, the lab technicians make the layering of the feldspathic ceramic over the abutment and over the tooth. We have the restoration. We try both restorations, the abutment and the feldspathic veneers over tooth and implant. As you can see, there is a little bit more of pressure on the labial aspect, so we have to be a little bit careful about that because we can have a recession. Maybe we need to take a little bit out there. The trying of the veneer over the implant, and once everything was okay, we adhesively cement the restoration outside the mouth. That allow us to clean really well the excess of the cement, polish very well the surface, and then place it in the mouth. And here we have a small video where you can see how the protocol works. You know, we prepare the ceramic with fluoridic acid, then silane, then bonding, and then the photopolymerized cement. We place everything, we light cure, and then take out all the excesses and place it back in the mouth. So here we have the final restorations at the mouth. And obviously it's really important to explain to the patient how she has to maintain the restorations, how to clean everything, because it doesn't make any sense to work those situations if the patient will not have a healthy environment. And you can see the integration of the restoration with the lips. And other point of view, you can see that the patient allow us to mimic small white spots that gives a lot of naturality to our restoration. This is a an abstract, a resume of our protocol for delayed implants. First of all, extraction and preservation with the weight pontic. Then, second, implant placement and again the weight pontic. And third, restoration with the bioconcept. Here you have final restorations in the mouth. Maybe there is a lack of a little bit of volume, but it's just for us. It's just for in the big screen. For the patient, it's much more than okay, the result. So we have to keep in mind that we work for patients. We don't work for keynote presentations in big screens in congresses. We work for patients, and the patient was happy, and I have to accept that. That's the final result. Light transmission, light reflection, it's very important to have a very good integration of the restorations. 1 year follow-up with a periapical X-ray where you can see we maintain the hard tissue levels. But sometimes we have the possibility to make a CBCT, and sometimes we can see that the bone in the vestibular part of the implant, it could be or not be present. It will be a problem. If the patient have a good hygiene, the stability is guaranteed with the soft tissue. But sometimes we can have troubles if the patient doesn't have a good hygiene protocol. So this is the starting point and how we end up. There is a big improvement in the aesthetics, and I can say as well that the patient has good maintenance, so I feel very comfortable, and I think it will long last for a long time, the restoration. You know, this is the high smile line and how we end up, and this is the follow-up 4 years after. We can see that we have acceptable soft tissue levels in distal papilla, where we perform the subcritical contour modification, and everything is working really well, and patient is happy. So again, the take-home message of the whole lecture for me will be the use of a weight pontic to preserve volume. Then you can change that weight pontic for a screw retain provisional restoration to keep maintaining the volume. You know, volume, it's key for the final aesthetic result. If we don't have volume, we won't have any natural looking restoration. As well, try to use the mix of materials in the final restoration using the so-called bioconcept, you know, titanium interface, T-base for the biomechanics, zirconia for the biological integration, and a feldspathic veneer for the biomimetics, especially when you treat implants and teeth, you know, because it can give the lab technician the same substrate, you know, the same kind of substrate, the same thickness of the restoration, and you will have more predictable aesthetic results. So again, I'm Ramon Asensio. I'm very happy to share with you my lecture on soft tissue management on the aesthetic zone and in implant restorations and implant rehabilitations. I will be very happy to you know, answer any of your questions. You can contact me through the international aesthetic course we are doing, or you can contact me in Facebook or Instagram. No problems at all. Very happy. Peace and love.